Good morning, everyone. I'm Dr. Neil Kelman, Chair of the Department of Family Medicine and Community Health at Mount Sinai. Welcome. And what a great way to start off our Grand Rounds year with Dr. Luis Padilla. I won't say how long I've known Dr. Padilla, but for a very long time. And if you really want to understand the definition of public service, you just have to look at the work that Dr. Padilla does. He's the Associate Administrator for the Bureau of Health Workforce. He's Director of the National Health Service Corps that has now over 20,000 clinicians nationwide. The Bureau of Health Workforce is part of our government that aims to better meet the needs of all for a well-trained, well-distributed 21st century workforce by strengthening the health workforce, connecting skilled professionals to communities in need. Prior to joining the Bureau of Health Workforce, Dr. Padilla was Senior Health Policy Advisor to the CEO of Unity Healthcare in Washington, D.C., which is an FQHC network with over 100,000 patients. He's a committed advocate for the underserved, a former National Health Service Corps scholar himself, who completed his service at Unity's Upper Cardozo Health Center, where he also served as its medical director. He served as the National Advisory Council on the National Health Service Corps for 2007 to 2010. And most importantly of all his credentials, he's a board-certified family physician. So he understands what we do and how we do it. Dr. Padilla received his Bachelor of Arts in Philosophy, Bachelor of Science in Biology from the University of California at Irvine, and earned his medical degree from Wake Forest School of Medicine and completed his family medicine residency at Brown University. It's our great pleasure to introduce him and to have him give our first Grand Rounds of the year. Dr. Padilla.
Thank you, Neil. Thank you for that very kind introduction. It's a pleasure to be here this morning and really an honor to present to you our work, some of the challenges around workforce. But before I get started, I just want to thank all of you for the work that you do day in and day out. As I was getting up this morning and thinking about this presentation, I thought about, the times where I was in residency up in Providence and listening to Grand Rounds like this. Hopefully, I won't bore you to death so early in the morning on a Friday. But I think the challenges that we're facing right now, I think each and every one of you, as you're entering your careers, finishing up your residency, starting your residency, or training those residents, are already making headway into those challenges that I'm going to talk about. Although they may seem insurmountable, we've been chipping away at them for decades. These problems are long-standing. The challenges of access to quality healthcare are long-standing. The challenges to primary care. But in the program that you're in right now, and the faculty that are training you to be those competent quality providers are really what it's about, addressing those needs across the country. And in particular, as Neil mentioned, my interest and my focus throughout my career has been rural and underserved populations. I consider myself a specialist in underserved care, someone who has taken family medicine training and gone a bit further and say, let's address these needs in vulnerable communities. Let's learn what it means to integrate public health into primary care, behavioral health, all the aspects that community health really involves. So I know that you're getting that type of training at the Mount Sinai program. And I thank you. I thank you for doing that. And I thank you. And I hope that you'll consider careers in underserved care and looking across the country and addressing these really enormous needs. So thank you so much. All right, so I am going to attempt here to share my screen, and hopefully we will be successful here. Let me know if you're able to see my screen. Yes?
You're good. It's
good
perfect.
to go. Okay. All right. So the talk today is really going to go around this sort of agenda, if you will, and I hope to achieve the objectives of this Grand Rounds is to make you a little bit more aware of the challenges, the workforce challenges across the nation, the role that we play as a federal bureau within the agency of addressing those challenges. Community-based training, I think your program The family medicine program there, Mount Sinai, and all of our teaching health center GME programs are really our model program that levers the idea of training the future workforce in community-based settings. That is, I think, and you'll see in my presentation, a proven method of having graduates go into communities that desperately need their services and commitment. I'll go over a little bit about our physician training and service programs. Hopefully, some of you are National Service Corps clinicians, whether you're scholars or loan repayers. We'll talk about that and some other programs. And then some of the resources, research resources that we have available and now ever growing, publicly displaying as much of the data that we have within our portfolios to the public. And are you seeing me advance this slide? Let me see. I might not be. Apologize here.
We're just seeing the title slide.
I apologize. There you go. I was clicking the wrong button there. There you go. There's the agenda there. Apologies. All right. So just to start off, to set the context here in terms of the challenges that we're facing, and this is, I would imagine, not new news to any of you here on this call. You're living it every day. The challenges of the burdens of meeting access to care, particularly in primary care, the increasing rates of burnout, the decreasing resiliency that our workforce is facing across the country, and certainly primary care has been facing this before COVID, but COVID, as I've mentioned before in some of my other remarks and public remarks, has made it much worse. We went into the pandemic struggling with meeting utilization across the country in all areas, and in particular primary care. Um, and so this is not new. The pandemic has made it much worse, and we're seeing some new developments and some concerning developments post-COVID now, particularly around the resiliency. And we're seeing it, and you may be seeing it as you're talking to your colleagues across the country, more unionization of physician groups, of provider groups. And this is, we believe, obviously, a direct response to the challenges and the pressures that physicians and other providers are facing across the country. So here is what we project to be the shortage across the country. You can see here that nationally, what we're talking about when we say adequacy is our models really are two models of workforce projections. One is, what do we project the demand for services utilization to be, and what do we think the adequate supply is? So when you're seeing 78, 100% is we're meeting all of the demand across the country. So nationally, 78% of that adequacy is being met. Obviously, this varies by geography, by state, by locale, and you can see there some of the lowest areas, including Connecticut, New Jersey, Nevada, Mississippi, Maryland, et cetera, have some of the lowest projected adequacies across the country in family medicine. So this is a daunting task for us, but I'm really happy to say, and I'll talk a little bit more about the Teaching Health Center GME program since it started in 2010. It really is our marquee program to address family medicine physicians. The majority of our residents that we train in that program are family physicians that go on and provide primary care. But we're only training right now a little over 1,000 FTE through that program. We hope as Congress continues to act and pass its appropriations that we'll continue to expand the program. But this is from a numbers perspective, one of the major challenges that we're facing. So the department has, and the secretary has initiated a health workforce initiative, and we think this is very important since before this, HHS does not have as a principal goal workforce development, health workforce development. So this is important at the secretary level to have this goal, the approach of leveraging our programs across HHS, not just, we're not the only ones that have workforce programs, CMS, the PA, et cetera, engaging with stakeholders like you and others to identify policy gaps and opportunities to enhance workforce development across the country. So just bringing that attention, that awareness at the secretarial level is really important for the department to keep moving forward in this goal. Having to toggle between two different things there, so I apologize. So at the Bureau of Health Workforce, our mission is to improve the health of underserved populations. And we do that by strengthening the health workforce through our various programs, but most importantly, connecting those students and trainees, those skilled professionals to communities in need, particularly in rural and underserved areas across the country. And certainly since I started leading the Bureau, we really focused on this continuum. And this is evident in the training that you're receiving. You came from a medical school program. You're training right now in a postgraduate training program. And then hopefully you're going to go on to serve in a rural and underserved community. Obviously, you may not do that, you may practice, but you're benefiting from a model of training that is going to prepare you to do just that. So we really see the portfolio, the constellation of our more than 50 workforce programs trying to lever this continuum, address the pipeline, make sure that we're supporting quality model approaches, innovative approaches of training, and then incentivize, encourage, if you will, provide even service awards to clinicians who go into communities where they're needed. So as we look at our overall aims through the lens of that continuum, we're talking about, as I mentioned before, the first part is increasing the supply, addressing what I just mentioned earlier on, that inadequacy that we see of meeting demands across the country. That for us is first and foremost, not just for primary care, certainly for family medicine, the discipline itself, but across all of our disciplines. It's important for us to do that because if you don't, it's really hard to achieve these other larger aims, whether it's equity, resiliency, improving the distribution of the workforce. So for us right now, and especially given the impact that we're seeing through our projection data as a result of COVID, the importance of increasing the supply of all disciplines across the country. And through the years, we've levered various strategies that we think are successful in doing just that. Many of these are evidence-based, really rooted in what's been working. I mentioned one community-based training that is taking students that have um, hopefully maybe a shared background to the training set, the practice settings that we ultimately want them to go work in, but ideally exposing them as longitudinally as we can throughout their training continuum in those communities that we hope that they're going to provide services. So recruiting students from underserved communities is an important aspect of what we do. Training students in rural and underserved communities like you're doing right now, expanding that community-based training environment through more training sites, and that includes leveraging our partners. I didn't mention that we have 3 other bureaus within the agency. We partner quite well with our sister bureau of primary health care led by Mr. Jim McCrae. Um, the health center that you're training in is funded by BIPIC, and we see that collaboration to be a very important component of what we do in exposing our trainees and students to communities that will need their services in the future. And we've taken strides to connect our 50 programs. It's quite easy for us in any environment to focus on, one aspect of our work and not really look for those ties and connections and that interconnectivity. Whether it's our pipeline programs like our AHEC, our area health education centers, our centers of excellence programs, or our loan and scholarship programs. Well, our attempt here is to try to link as much as we can and even try to braid that funding, as challenging as that may be, to uh, increase the overall impact of our program. The THC GME program at its base funding is 126.5 million. As I said before, it's training a little over 1,000 providers. But that program alone is not going to address many of the issues that I'm talking about. So as an example, a few years ago, we linked the THC GME program to the National Service Corps. That is, we gave graduates of residency programs like yours priority to get loan repayment for the National Service Corps to incentivize them to continue and to utilize the training that they received through the TAC GME program and then offer them loan repayment to go into areas of underserved. So it's just an example of one way that we're trying to link our various programs. Obviously, integrating behavioral health and public health into primary care is sort of a tactical approach, if you will, to try to make sure that the dollars that we support programs with are offering that level of integration. And certainly right now, with the behavioral health needs that we have and the impact of public health as a result of the pandemic, those 2 particular areas are critical for us to continue. So here's a snapshot of our various programs. As I said, we have 50 plus programs. I don't want to rattle off all of these numbers, but I want to just highlight a few here. The pipeline of diversity. As I said, that continuum of education, training to service is important. Where are our trainees going to come from? What school you went to, the undergraduate school, even maybe even the high school, are targets of our programs. So that 400,000 participants, over 400,000 participants in our pipeline diversity program are critical for us because they form that supply of future providers, if you will, whether it's in medicine, nursing, allied health, behavioral health, they really form the basis of our future workforce. So our ability to increase that pipeline is critical for us to meet many of these goals. And as you can see here, we have really the opportunity through our Bureau to impact various segments of healthcare, whether it's oral health, geriatrics, public health, nursing. We really touch almost every aspect of healthcare and public health throughout our various programs. And again, the challenge for us when we have that many programs is how do we connect them? How do we lever one to the other? And many of these programs sit in different divisions within the Bureau. So again, you can imagine having 12 leaders that run these divisions talk to each other, work with each other, integrate your work, know what's happening in the division. Is this sort of an operational challenge that we encounter and address on a day-to-day basis? I'll transition here to the budget. We always start out our federal process with the budget, the president's budget request. Here we're operating right now in really essentially 3 fiscal years. I'll give you a crash course on government financing here. The federal government runs really 3 fiscal years at a time. One is that current fiscal year. We're in now fiscal year 24. And this was the president's request for 24, a budget request of 2.71 billion to support our work and other work in terms of health workforce development. I think an important message to Congress is this goes to Congress every spring, but we're also operating in FY25. That is that future fiscal year. What's that going to look like? We're developing now the president's request for our workforce programs. That's going to go into congressional justification that goes to Congress. And then we're thinking already, right as soon as that congressional justification goes out, we're thinking about fiscal year 26. So we're constantly looking at those 3 streams, and it causes challenges for us. But where we are right now is 24, a critical time right now when Congress is deliberating on 12 appropriations bills, a ceiling budget that's non-defense of a little over 17 billion that's going to impact all of our programs, so including the THC GME. But in addition to the budget concerns that we have, what's our appropriations going to look like? We have 2 key programs that are up for reauthorization now. All of our programs are built on authorities, laws that Congress has passed. All of those are authorizing legislations to run a program. Now, while we can continue to run a program if you don't have authorization, and we do have programs, titles of laws that have not been reauthorized, essentially Congress is doing that when it passes an appropriation. So right now we have the double concern of we don't have a full appropriation, and then we've got 2 key programs that have authorizations that are going to expire by the end of this year. That's the National Service Corps and the Teaching Health Center GME program. So in the president's budget, the request is 3-year extension of that mandatory funding, 3-year extension of the mandatory funding for THC GME, and here are the levels: 2.37 billion over that 3-year period for the National Service Corps and 841 million over that 3-year period for the Teaching Health Center GME program. So as we see the deliberations in Congress right now, both on the House side and the Senate side, where they're going to ultimately land, hopefully it's as close as possible to the president's request, because we've taken great pains to estimate how we would utilize that money for both of these programs and what the American people would get for that money in terms of training physicians and supporting clinicians across the country. So I mentioned the THC GME program quite a bit here. It's not the only postgraduate community-based training program that we have. We support nurse practitioner residency programs as well. We support fellowships in the form of addiction medicine fellowships. But when you look at our postgraduate training, the model really is the same, and that is how do we lever as much as possible community-based training? We understand that when all of you as residents complete your training, the likelihood is within a 50 to 100-mile radius of where you completed your training, you're going to set up your practice. You're going to start seeing patients in that community. So it makes sense for us to try to really focus on postgraduate training, emphasize community-based training in the hopes that you're going to stay there and provide those services and quality services to that community where you ultimately are going to reside and raise your family, complete your training and start your careers. Right. So through that effort, that focus on community-based training, we've seen a good increase. Now you may say, well, 10% in 2023, that's not a whole lot when you consider the number, thousands of training sites. We have over 30,000 training sites across the country. But we started out with a level of just under 5%. So in the few years that we've started this, we've seen a dramatic increase. And again, that partnership with our FQHC partners is really important. They, to me, as I stressed to Mr. McCrae, Jim, and others, you really are the backbone of that training environment. My charge to them is, why can't you be the premier training environment in the country? If you're striving to be the premier service delivery model in the country, I think the flip side of that delivery model is quality training programs. It ought to be the environment that every medical student aspires to train in because it's quality training, effective training, and prepares you to provide services across an array of challenges that you're going to meet in any community. So we're pushing towards that, and we see these metrics here as a positive stride towards that overall effort.
What happened in that last bar that it went down when we're trending up all that time?
Yeah,
Idea?
good question. So there's a couple of, you know, our training sites are really impacted by the ability of networks and health centers to offer that training. And what we saw is a dip in some of that. So we're not really clear the specifics on how many of those sites just couldn't do that anymore, but we did see a dip. I'm glad that you noticed that. And we're trying to track that as well. I mean, the reality is, and certainly as you talk about education and training, and Neil, and I think that with you asking that question, it's a costly endeavor. And when you're trying to create education and training models in an environment that is a nonprofit environment, the profit margins are thin, the operating margins are thin, and there's not a lot of room for error. And I think in this scenario, I think what we're seeing here is a number of those are the training sites where we say, look, we just can't operate. We had some closures of FQHC, we had some reductions in services and some consolidations as a result of COVID. And I think that might be behind that slight dip that we're seeing. Thank you for asking that great question. Thank you. All right. So talking about education and training, one of the things that we kicked off a couple of years ago was our health profession education and training initiative. And this was the partnership again with our Bureau of Primary Health Care, where we said, if we want to really push this community-based model, we have to have a better understanding of the capabilities that FQHCs have in doing this. Like, where are they now? And we didn't have a reasonable database to assess where they are in their development. Are they doing training now? What is their capacity to do that? And where are they in that continuum? So we undertook this in 2020 and started out in year one to develop what we call the readiness to train assessment. This was developed by Margaret Flinter and the group at CHCI Inc., who also developed the patient-centered medical home assessment, which was an evidence-based tool. And this was a similarly fashioned evidence-based tool to assess what is the readiness of health centers across the country. So we did that first year, deployed that survey in the midst of the pandemic and got an enormous response, 78% response to the survey that was put out in the tool utilization. So then following year, analyzing those results and then asking the health centers to develop a workforce action plan based upon those results. And obviously there are limitations to any survey methodology, the results that you get, who's answering that, their awareness an ability to understand what's happening across an entire network. You may have, for example, where I used to work at Unity Healthcare, we had 13 health center sites in our network. Our one contact that was doing education training had to have an understanding of what was happening in all those 13 sites. Well, there may have been limitations in their understanding of what was happening at each of these sites. Nevertheless, it was the first time that we got data in terms of where health centers were. So we had the ability to take a look at over, I think it was 800 health centers across the country, and where they were in their continuum. And that was important data for us to start to look at, because what we found was some of them were doing, almost all of them were doing training. There was a good portion of them that was um, doing really high level training, which includes obviously GME training, but there were some that were just on the cusp. We saw from the readiness tool that what they needed was they had all the infrastructure, they had the institutional buy-in, but they needed resources. Others were further back. It wasn't an issue. It wouldn't have helped to give them resources because they didn't have many of the infrastructure important evidence-based elements that the organization needs to even start education and training of any discipline, let alone primary care. So that was done in year 2. In year 3, all that information was disseminated out to health centers and primary care associations across the country. We began work on implementing workforce action plans. We started the process of disseminating through our efforts and BIPIC's efforts, those evidence-based models and promising practices, including THC GME, and started to begin that data set of an evidence of demonstrating sustainability and return on investment. Programs like Margaret's program and the nurse practitioner residency program that demonstrate over a 3-year period, there's a return on investment. That is, what you're putting into the program, you're getting back, you're at least breaking even, maybe even a little bit more to support those training programs. And it's important to demonstrate that because oftentimes what we see is organizations like this don't have institutional buy-in because they're worried about the financial sustainability of these education and training programs. So let me move to the THC GME graduate medical program because this is really our model program. And we understand not every health center, not every organization is ready to do this level of training. There's a huge commitment, as you all know, resource intensive. But since its inception in 2011, and we've gone from 6 programs now, or FTEs here from 6 to a projected 2,828 if we were to get the funding that we need in 2024, 24, 25. Quite an enormous increase in overall FTEs of primary care and other disciplines because the program does support oral health providers and it does support psychiatrists and geriatricians and some OBGYNs whenever they come in for our funding. But the majority of them are primary care. So this has been an enormous success for us, and it's really been a model, and Congress has taken notice. Many of the bills that we see right now are asking us to increase our overall footprint of the program. There are some proposals on the Hill, including from Senator Sanders, that would like to see a teaching health center in every single state. Some more statistics here on the teaching health center GME program. And I think in any program where we have the ability to tell this story, it's important to note that while residents are training, they're seeing patients. They're delivering care. They may be precepted, of course, they're not completely on their own, but they're providing care. And I think all of you, when you're seeing patients, should remember that. I'm providing services here. Yes, I'm being precepted, but it's an important facet of overall care that you deliver even during your training. So you can see here that the funding now supports 82 residency programs in 27 states. The clinical training site details here, 63% of our sites are in medically underserved communities, again, emphasizing that community-based training model. 50% are in primary care settings, and importantly now, 19% are in rural areas. And here you can see 76% of grantees or FQHCs are lookalikes. And when you look at, when we recently put out a planning and development grant, that is funds to support the development of residency programs, 95% of those awardees were FQHCs. So we're really right on track in terms of our community-based training model and partnering with FQHCs to develop this kind of training within FQHCs across the country. So we're going to keep touting the benefits of this program. When you look at residency programs and some key aspects of any residency programs, the THC GME program is really outperforming what we would consider a traditional training model. Whether it's in rural areas, the graduates who finish these programs, where do they go and reside and provide training within a 5-mile radius of their residency completion? We see almost 20% here, 18% versus 12%. In terms of medically underserved communities, again, this is the evidence that that model helps and really works to provide access to care in medically underserved communities. Training students and residents in these environments leads to them staying and providing services there. And again, in FQHCs and lookalikes, 26%, over 26%. And again, it makes sense. You're spending 3 years, 4 years of your time in this environment, and say you may have gone to medical school in that geographical area. So there's a longitudinal continuity that occurs. While I was at Unity before I left, they started training medical students. They were starting the process of working with the right center and becoming a THC GME site. So they were training medical students at their sites, they were training residents. So think of it, that was almost a 7-8 year period of time that those individuals are going to be in that system of care, ready to either work for Unity in the future or provide services in other medically underserved areas or sites. So in terms of our funding right now, we have an announcement that's closing today. This 126.5 million is the base funding for those pre ARPA, the American Rescue Plan Act funding, that cohort, the base cohort, if you will. They're going to wrap up their recompete applications today, and we'll be deploying hopefully the full amount of 126.5 million for this grant supporting 57 awardees. And we hope that in the next year, as Congress acts, that we'll be able to fund as many of those planning development and new and expansions of our training health centers as possible. We awarded in July 175 million, over 175 million to 81. This was the last award of our ARP funds that we utilized that expanded the number of awardees and the number of residents now to almost 1,100. So just to recap here, 806, if we don't have funding, so we're supporting right now a little under 1,100 residents. If we don't get the funding that we need, if there is a significant reduction, here's some of the impacts that we would see. We could see ceasing of operation of 73 programs, a total of perhaps 867 residents. These are individuals who have their training interrupted. And I can tell you, I experienced an interruption in my training, my residency training, and it was not fun. Fortunately, I was able to stay in the program, within the program. But you don't want your training interrupted as you're completing your training over a 3-year or 4-year period. In the midst of that, to go find another residency program would be enormously disruptive. But I want to mention a couple of other key programs. As I'm not going to go over the whole 50-49 complement here, but our work around geriatrics has been going quite strong. And that is another model of integrated training and care that we've been supporting for several years. It's open now, 43 million to support 43 awards. And many of these, over 75% of those awardees partner or offer training opportunities in FQHC. So an important part of our future geriatrics workforce is this program. Our primary care training and enhancement program that focuses both on physicians and physician assistants is just out. It's open until March. And there's 3 objectives, really new objectives in that funding announcement. One is to provide a 3-month longitudinal training for PAs in rural areas, to develop curriculums of behavioral health and primary care integration, and to offer more exposure earlier on to those rural environments through this funding for students that want to do rotations or residents that want to offer or do rotations in rural settings. So we're excited about that going out, and it's out until March 15th. Another really big part of what we do to support the physician workforce is our medical student education program. And this is a program that was funded a few years ago by Congress to support, in part, and focus in on tribal entities that have partnerships with medical schools within their states. And I'm talking about like states like Oklahoma, Missouri, that have large populations of tribal members and students that are going to school. And this program is really intended to support their educational training. And we're taking strides to adjust this program to have them continue on and maybe even partner with THC GMEs. As these medical students want to do clerkships and internships, could they go do them in our THC GME program? But one of the exciting features of this program is we've just put it out for the last round of competition is to develop a post-baccalaureate program. Again, going back to that pipeline, how do we have students, the diversity of students and the pipeline of students come into these training programs and the types of students that we know historically will go into underserved areas, will diversify the profession, and will provide primary care. So we're excited about this being forecasted in 24. Once the appropriations bill is finalized, we'll get a sense of how much we have to put out in this forecast to support these 12 medical schools. I'm going to be cognizant of time here, so I'm going to go a little bit quicker. The National Service Corps, and I'm sure that some of you have benefited from this program, as Neil mentioned in the introduction. I benefited from it in 1998. Had not been for this program, I don't think I would have been able to complete my medical education. My family couldn't afford the tuition at Wake Forest University, and I would have really struggled to stay in the program because of financial constraints. In the 50-year period that this program has been in existence, we're talking about over 60,000 alumni. It really is one of our marquee programs is supporting a broad array of physicians, physician assistants, and nurse practitioners across the country. As Neil mentioned, we're right now at historic highs. We think that if we get the level of funding, well, we know that if we get the level of funding that we've asked in the president's budget, we'll continue to grow that field strength over the years. But one thing about this program that it's evolved quite significantly over this 50-year period. It is no longer just one program. We actually have 10 umbrella programs under the National Service Corps. I think people don't realize that we're even operating programs that are not within these authorities of the National Service Corps. Things like the Pediatric Subspecialty Loan Repayment Program that just deployed, the Substance Use Disorder Loan Repayment Program, our Substance Use Treatment and Prevention Program. These are programs that Congress is funding that is not using the National Service Corps Authority. But what they've said is, you all have been doing this for so long, you do it so well, you have an established infrastructure to support other loan and scholarship programs. We want you to do this too. And we're ready to do more. There's an underlying IT system that runs this program. For those of you who applied, there's one application, and you can pick different programs through that one application. And we're continuing to innovate this system to make it easier to apply, to have more flexibility in the programs that we offer, and to be as transparent and engaged with clinicians and applicants as we can. So really the program is not what I remember it being in 1998, and we're going to continue to innovate to meet needs across the country. So here's a snapshot of just a couple of the programs, these sort of our core programs, if you will, and what they offer. As you can see here, and this is what I was saying, is these are just 3 of the 10 distinct programs that we have. Even though they're under the same authorization, they're distinct programs with different levels of funding, different time periods, and sometimes some different requirements. All right. So just to mention here, one of the things that we offer is the Health Workforce Connector, and hopefully, and there's a link here at the bottom of the slide here for you to take a look at. But when I was a scholar looking for my placement in 2001, I think it was, yes, years and years ago, we didn't have this. What we had was a spreadsheet. of sites across the country, and they asked me to, can you call these sites and figure out if they have openings and for you? Because I had to go to one of these sites. And oftentimes what I found was the point of contact that was on that spreadsheet was gone. The phone number was incorrect. People didn't know who to refer me to. So it was a bit of a challenge. And those days are long gone now. We have a platform that has over 56,000 sites, 9,000 opportunities across the country. We just finished a job fair right now that's linked to the Health Workforce Connector, a virtual job fair, where we offer virtual um, job fairs for positions across the country for not just National Service Corps, but Nurse Corps clinicians and other clinicians who are trying to find careers in rural and underserved areas. So I encourage you to take a look at the Workforce Connector. One of the exciting things that we're going to be doing through this portal is this website is putting all of our academic training sites on this connector. So imagine in the near future, what I would like to do is have a residency fair. So here's a virtual job fair. I'd like to have a residency fair that highlights all of our THC GME residency programs to assist you in the recruiting effort for your incoming classes. We have the ability to do that, and that's something that we're striving to do in the very near future. All right, so just a couple more slides here and I'll open it up for questions. It's important that we put out data. Not only do we have a few laws that govern this, that require us to put out data, but we do a step beyond that. And that is, we think it's important to publicly face as much of our data as possible, whether it's our health professions reports, evaluations, survey data that is now all online. All of that information now is accessible. Our performance data, our loan and scholarship grantee data, that is, you can go down to the state level through any of our loan and scholarship programs and see how many applicants did we get, how many awards did we give out by state. That information wasn't available as of a few years ago. So it's important for us to not only comply with existing law in terms of Evidence Act or the Data Act, but it's important for us to put this information in the hands of our stakeholders. This is key, not just for policymakers, but just for the public to know where are all these dollars going and how is it being utilized and what's the overall impact of those investments. Right. So our challenges remain. We're in a post-COVID state. We continue to get surges, obviously, but the public health emergency is over. We're now really faced with sort of the aftermath, if you will. We've now started incorporating the first year of what we consider to be COVID data starting in 2020. And then we just got the 2021 data that incorporates that. So we'll start to bit by bit see the overall impact that COVID had on our workforce, whether it was the distribution, the supply, et cetera. But we also will be incorporating nursing survey data. We administer the largest survey to nurses in the country, over 400,000 respondents back. And it's an important cross-section of the nursing workforce that is also going to include COVID data to show what's happened and what happened in the last few years. So these challenges that I'm putting up here on the slide, whether it's distribution, access, as I mentioned, clinician well-being is at the top of mind. Sadly, suicide rates, substance use disorder rates, mental health issues among providers is increasing. It was high already before COVID. It's higher than it's ever been now. And we want to continue to use whatever investment Congress gives us. And even if they don't, looking for ways to use our existing funding to incorporate more resiliency and clinician well-being efforts at the organizational level if we can. Because it's not going to be enough to say, oh, well, we have a wellness program for residents, or, we debrief with them. You have to look at the organizational factors that are contributing to burnout and the lack of resiliency among our workforce. And we have funding that's doing that now. We hope Congress will recognize the importance of that particular effort and continue to fund our effort. But if not, we're going to look for other ways to continue to support organizations in addressing the factors that are contributing within their health systems to burnout. These are some of our top areas where we're really have, as I see it, opportunities, whether it's in behavioral health, maternal health, Again, community-based training is a tactic, an evidence-based effort that we're going to continue to deploy across all of our programs. So let me just end here with some resources here. We've provided hyperlinks to the resources, some of which I've mentioned already. I encourage you to take a look. Stay tuned if you're one of the faculty members who would apply for one of our funding. Subscribe, take interest in what we're doing. You may be taking interest already as you're looking at our loan repayment efforts and our opportunities that are coming up in 24 and beyond. So with that, I'm going to close, and I'm going to thank you all for allowing me to spew on for probably one of the longest talks I've given in quite some time, 40 minutes. So I hope if you've taken a nap, if you want to wake up and answer or ask me any questions, more than happy to answer any questions in the time remaining. Thank you.
Thanks so much. Wow. There's a lot of great stuff. I mean, you know that we're great advocates of the Teaching Health Center program. We have 2 active programs. We were in the first cohort of 11 programs, and our Harlem program came on after that, which is totally funded by Teaching Health Center. We have a 3rd program in Brooklyn that's got a development grant, and we're accreditation coming up any day. And so, we're in there pushing. Interestingly, New York, we found out, has about 9 health centers that are currently in the pipeline with development funds or starting training. So we're gonna get New York off that list that you showed that had the highest projected needs in the future. But I think the health centers in New York are really, they've been seeing what's been going on with a couple of the programs that exist now, and I think people are really pumped about getting in. So we're hoping for the to promote the funding. Red?
Yeah, thank you, Louis. This is great. We also have a nurse practitioner residency program that's HRSA funded, and so we're really grateful. I guess one comment I'd like to make is that, which you highlighted, is we've discovered that providing teaching and training programs at FQHCs really helps with the recruitment and retention of the staff. Not just the physicians, but the nursing staff, the support staff, will all get engaged. I guess the question I have is, there's a lot of whiplash with this program when it comes to funding and the challenges of continuing the funding. What are the thoughts about a model that sort of more like CMS, where we really can get away from this constant up and down of being at the whim of an authorization and ultimately the politics of DC? So are there any thoughts about sort of where we could go in 4 or 5 years with a more sustainable model of funding?
Yeah. And first, Red, thanks for that. Those are really great questions. Let me just speak to the first comment you made about having a nurse practitioner. I think it's awesome that you guys have a nurse practitioner residency program, because it really highlights the organization's recognition of, we need to support nurse practitioner residency programs, and we're going to do that training. So I think, kudos to all of you, and I'm glad that you guys have our funding for that. And just on that, I spoke at the first conference that Margaret hosted in Denver years ago to kick off that consortium. And at that time, we were talking about maybe 50 programs. Well, we're at over 400 nurse practitioner programs across the country now in that less than 10-year period of time. So enormous growth there. And when you look at the rates of hiring of nurse practitioners at FQHC, it's really an important part of that residency program that really shouldn't go understated. Your remark about more, quote, permanent funding, if you will.
Yeah.
Well, right now, the Teaching Health Center GME is under mandatory funding, right? So Congress, you have to fund these programs, under this mandatory legislation that you have in the National Service Corps and other program. The health center program is under mandatory funding, right? So you have that. And there have been calls for what you're saying is, why don't we make it like we have CMS, where they get this funding every year and they put this out? I wouldn't disagree with that permanent funding, if you will. I would just sort of put the yellow flag up of, let's be careful about having it be a CMS program, because
Oh, yeah.
this is right. And so that's where I think some stakeholders
No,
Yeah.
bring
no.
this up and say,
that
let's
they
let's
have,
not, because when you put it under CMS, then you're putting it
sure.
back under that overall structure. So I just want to disentangle that, because I don't think I certainly would not argue with permanent funding, right? But I would quibble with, well, let's not change the model, because there was a reason why we developed this. But I don't think you're going to get any disagreement with me. Stability of funding is one of the key aspects that we've seen, and you've experienced this whiplash. That, you're trying to recruit residents in the fall, and you don't even know if you're going to have money to start that class up the following academic year. So we really need to, and when we signal that to Congress every time they ask. And I'll tell you, your advocacy and the advocacy of others is important, because wherever you can plain speak the issue in the program, this is what we do in plain English, so that they understand, oh, I understand your funding. It's not like a historical grant, right? They don't understand that you're recruiting clinicians in even before they start, right? Even before the period of performance and that academic period starts. So there's a lot of education that needs to be done on the Hill. But I agree with you. We're not the ones to advocate on the Hill and say you should fund it this way, but certainly I've heard that from stakeholders.
Yeah. And just one comment that let you know that there are applicants to the residency program that are specifically interested in teaching health center programs.
Yeah.
So just to let you know, this pipeline effect is real when we interview applicants.
So, and I don't know, Brad, if you were there when I spoke and I gave my personal story about my residency program, but I trained it at Brown's Pawtucket Memorial Hospital in Blackstone Valley. And I only applied to residency programs that partnered, and this was in 2001, that only partnered with FQACs. And at that time, there was probably about 10 of them, maybe, across the country that did that. So those were the only ones I applied to. And so even then, and I wasn't alone, when I went to that program, everyone there, they're like, yeah, that's why I'm here too. I want to train in this environment. I want to train in this community, in this population, because I see myself, and I saw myself, that's where my career trajectory is going to go. And the Luises of the world, if you will, and the ones that come before, there are even more. The faculty that I was trained by, they were graduates of that residency program. So when that medical director decided to end that residency program and its affiliation with Brown, it created a ripple effect that he didn't understand, and cut off the pipeline of not just the faculty, but the future clinicians that were working at that site. And so it really does, as you were saying, the recruitment and retention of staff, having a training program at this level has a ripple effect across the entire organization.
Thank you.
So I'm going to just read you a couple of questions. Maybe you can, Dr. Maritato, who's one of our residency directors, directs the Harlem program, asked, we do love the Teaching Health Center, but so many programs are CMS funded. Why isn't there a mandate to train primary care at hospital sites? It feels urgent and imperative.
No, thanks for that question. And so I think this speaks to sort of the creation and the reason why this model of training was created. And that is, so much of physician training was historically done in hospitals and continues that is the predominant training modality and model. I think what distinguishes the Teaching Health Center GME program is that it does not fund hospital-based residency program. It funds community-based, and that's in our legislation. So it's a it's a paradigm shift from the way CMS supports its residency programs. So we continue to support residents in hospitals. And in fact, all of you are training in hospitals, right? I mean, there's no way that a health center can provide the full constellation, if you're just going by ACGME requirements, the full constellation of meeting those requirements and training requirements in an outpatient setting. There's no way. So that partnership exists. I think this program is saying we are going to be intentional in funding these community-based organizations, unlike other programs that fund hospitals. And I think that's a very unique program that I would not want to see change. But at the same time, continuing to develop hospital training, but my bias is we need more community-based training.
Well, when we're talking out there to the legislators, we always point out that HRSA is a grant program, and the grants come with requirements and specificities about who we train and what we do, and that's really so critical, where the hospitals can train any doctors in any kind of specialties they want.
And I don't want to disparage my colleagues at CMS, but so I hope they don't take if this gets back to them. All the metrics that I showed, they don't have any of those metrics.
Yeah. There's no
Okay?
accountability.
There's no like, oh, where did
yeah.
they go? Who did they see? What
Right.
There's none of that. And you get that when you're running a grant because there's an expectation. Yes, there's a burden, but you could see the result. What are you getting for the 126.5 million? Here's what you're getting.
Well, we run a program at Mount Sinai, and we had a close call with it just a couple of months ago, where there's the same commitment that federally qualified health centers have to training in family medicine. It's much harder for hospitals to see the value of that, when their whole focus is inpatient. So there's another question. It says, has there been any insights that inform how best to engage clinicians beyond their service commitment in the loan repayment program? How do we keep them after their loans have been repaid and whatever?
I think that's a great question. And when I was after I completed my service, I was on the advisory committee to the National Service Corps, and we used to have an ambassadors program. I don't know, for those of you who maybe have been involved in the program, remember that. You may have been ambassadors, but I was an ambassador, and we ended that program years ago. Another thing that ended was we used to have conferences for loan repayers and scholars, and I was a participant in those. Because of certain issues in government funding, that had to end as well. So we're challenged right now to find how to connect. And that was really one of the genesis for this Health Workforce Connector. When I started, I saw this being developed and said, that we're losing this ability to connect with individuals after they complete with us. And we want to find ways to lever that. We're also looking at the ways that connections are made now. The way that they were made in 1998 when I was a scholar is not the way. Now we're using this as a form of connection, right? I see it in my kids, and certainly the younger generation is using social media. It's using mobile platforms. It's using connections on the spot. I don't think conferences are a way to go, but we're looking at how do we use existing technology right now and what we have to connect our alumni to existing participants. Now, we deployed a contract last year and using a contractor to support current loan repayers and scholars, principally scholars, because we know that they need some assistance and support as they're transitioning from their training, from their medical education to their training, and then from residency into practice. So we're trying to do that internally to the current cohort. But I hear who was asking that question. Yeah, but how do we do this after they've completed those alumni, those 60,000 plus? How do we keep them in the fold? And that's what we're trying to work on right now. What's the most effective way of doing that?
So I'm going to read the last comment because I can't think of a better closing comment. It's from Dr. Blevins, who's a behavioral health science faculty in one of our family medicine residency programs. She wrote, I received loan repayment from the SUD NHSC program. I think I may have been one of the first behavioral health providers to be able to apply for full-time status after the expansion for behavioral health providers with teaching roles in teaching health centers. I just want to say thank you and highlight how important that expanded funding is for integrated behavioral health, resident training, and well-being physician burnout. And we're big behavioral health providers at the Institute in all of our programs. So, so somebody's saying thank you.
Well, you're welcome, and thank you for applying, as we don't require people to apply. So thank you for applying and making that commitment and that obligation, because you signed on the dotted line for something, right? So thank you so much. And to be honest with you, credit to Congress for doing this and putting the money out. I mean, we continue to tell Congress, you give us the money, we'll deliver. You just need to give us the funds to do what we've been doing for 50 plus years in that program. And so I'm glad to hear that. And, you know, Neil, your talk about FQHCs and behavioral health, that's another area that Jim and I are talking. There's so much need there. And he
Huge.
sees it in his data where he's not meeting that need, right? Less than 20% of health center populations are getting the behavioral health care that they need, right? And so they're gonna need our support for that workforce, and whatever we can do to support that, again, that strong partnership, we're going to continue to do that. So thank you, Dr. Blevin.
So I'll just tell you that we do over 500,000 visits a year, and almost a third of those are behavioral health in our system, 30 sites. But you know, it's a huge piece of what we believe in and what we do. Thank you very much. You'll be happy to know that when we run around Congress now talking about funding and stuff like that, that almost every office we go into knows what a teaching health center is. You know, we used to have to explain the difference and how the funding was different and the outcomes were different. But a lot of that is to your credit, because the outcomes and things that you showed us are out there, and people understand how different this program is from CMS and how important it is for the workforce. It's sort of selling itself after, you know, I guess what, 12 years now. It's starting to sell itself. All the congressional people want them in their districts, and I think it's really, you know, we said early on we thought this was the training model of the future, and I think it truly is, and it's showing itself to be that way. And health centers are stepping right up to do the work. So it couldn't be better placed. And a credit to you and to all the people who've been, you know, promoting this for all these years. And thank you for joining us for Grand Rounds. We appreciate it. We look forward to continuing to work with you.
All right. Thank you so much for the invite. It was a pleasure. Thank you so much.
Thanks, Louis.
Thank you.
Care.
Take care. Thank you.